Welcome, everybody. We're going to wait till 2 o'clock or maybe 1 or 2 past the hour and get going. Welcome, everybody. We're just going to wait a few more minutes before we get going. Thanks for being here. We're right on time. Oh, I see Lori Herndon. I haven't seen you in ages. Thanks for joining. So we'll just give it one more minute. So thank you all for being here. You have joined the U.S. Deprescribing Research Network webinar for this month. Today's webinar is on tackling deprescribing in skilled nursing facilities. As I said, this webinar is sponsored by the U.S. Deprescribing Research Network with funding from the National Institute on Aging. I am Dr. Jennifer Chia. I am a geriatrician and palliative care doc at UMass. But more importantly, I get to co-lead the Investigator Development Corps with Dr. Ken Bookfar at UAB Birmingham. And before we get started with the webinar, I just have to cover a few technical details, so bear with me. Due to the number of people on today's call, we've placed all the lines on mute, so there's no audio feedback. So unless you're logged in as a host or panelist, you actually can't talk, you're muted. But we do welcome and encourage audience participation, so please use the Q&A feature on the Zoom webinar software. And when you would like to interact with our presenter, click the Q&A bubble icon on the bottom of the toolbar and type your questions in the box. If you'd like to be anonymous, you don't have to put your name in. And Ken will acknowledge questions during the final 15 or 20 minutes of the webinar. If you have any technical or logistical problems, we ask that you submit those separately in the chat box and click either the co-host, Jonathan Norton, to chat privately, or Vanessa Duodu. Please make sure that you are identified either by name or participant ID, so the host can troubleshoot with you. And I do need to give a shout out to the people behind the scenes who make this happen, including Vanessa Duodu at UMass, Jonathan Norton at Johns Hopkins, and Gabriella Schiller at Mount Sinai. We are just so grateful, and we never get to see them. So I just want to give a shout out to them. And now, without further ado, it is my great pleasure to introduce Sarah Berry. Sarah Berry is a wonderful geriatrician and clinical researcher at the Hinda and Arthur Marcus Institute for Aging Research at Huber Senior Life, right there in Boston, Mass. Her primary research focus is on preventing injuries in older adults, including preventing falls, fractures, and adverse medication events. The majority of her clinical and research efforts focus on the nursing home setting, and her current funding includes a large observational study to determine the safest drugs to treat cardiometabolic disease, as well as a pilot trial to develop and implement an effective program to prevent injurious falls through optimizing medications in the nursing home. Today, she is going to talk about deprescribing in skilled nursing facilities. So I'm going to hand that over to you. Sarah, if you want to share your slides. Thank you so much for being here.
Great. Thank you so much for that nice introduction and for having me here today. Can you see my slides? All right. Here we go. Great. So I'll start with my disclosures. All right. So although a little atypical for a research talk, I think I'm going to start with a case. This is a recent admission of mine, a 78-year-old man who was admitted to a SNF after a hemorrhagic stroke. His other pertinent medical problems include atrial fibrillation, hypertension, dementia with behaviors that got markedly worse after the stroke, urinary retention, kidney stones that he's not going to pass. He's going to require surgical intervention for them, and constipation. He's on 22 different meds, including a number of different high-risk meds, such as baclofen, meclizine, trazodone, and 3 different psychotropics. He's independent in feeding himself, but he's totally dependent on all of his other activities of daily living. And in fact, he requires 2 people in a Hoyer lift for transfers due to the aggressive behaviors. The nurse to patient ratio on this unit is about 1 to 18, and they're heavily reliant on agency staff. And when you talk to his family, they're quite insistent that his goals include life-prolonging measures, right? You know, this case just illustrates some of the challenges, but also the opportunities in deprescribing in the SNF setting. So in the rest of our time, I'm hoping to highlight some available strategies that are used to reduce polypharmacy in SNFs. For you to be aware that patients with falls and fractures are perhaps a good candidate for targeting deprescribing efforts. And then to discuss a model of care to promote deprescribing and to reduce injurious falls in SNFs. And for the rest of this talk, when I talk about a SNF, a skilled nursing facility, I'm referring to both their post-acute care as well as long-term care capacities in these facilities. All right. So starting just a little bit of background, I don't think I have to convince this audience that polypharmacy is a real problem in SNFs. In fact, 40% of residents are like the one that I presented, and they're prescribed 9 or more prescription medications. 80% of residents are taking a psychotropic. And then when we look among residents with dementia, I think in particular the psychotropics becomes even a little more concerning, where 1 out of 3 residents with dementia are prescribed 2 or more psychotropics, and 1 out of 8 are prescribed 3 or more psychotropic drugs. So this slide just shows some of the common medication classes among SNF residents that have polypharmacy. You can see that laxatives top the list, falling closely behind, and perhaps good candidates for deprescribing include antidepressants, proton pump inhibitors, aspirins, antipsychotics, even ACE inhibitors. But then if we believe that polypharmacy is a real problem, I want to spend some time thinking about what's currently being done and what strategies we have to decrease polypharmacy in SNFs. And I think it starts with regulations. You're likely aware that SNFs are highly regulated, much more so than hospitals. In fact, that's sort of the joke in my geriatric training was, you know, next to the nuclear waste industry, nursing homes are the most regulated entity in the country, right? So this slide, this timeline just sort of highlights some of the regulations that have been introduced with the goal of reducing polypharmacy in SNFs. It starts in the 1970s, where there was a regulation to that at least monthly, a pharmacist has to review all medications. And this regulation is still in place and is sort of morphed into the consultant pharmacist role, this external consultant that still does these monthly reviews today. In 1987, as part of the OBRA Reform Act, there was a regulation passed that residents should be free from unnecessary drugs, or specifically every drug, every medication that's prescribed needs to have an indication. And this regulation is still in place today, must have an indication for every medicine. 2002, a regulation that every resident needs and deserves a person-centered care plan, and that this has to be regularly updated. And then in 2011, part of the Affordable Care Act, there were some additional reforms. And among these was the mandated reporting from all facilities of the number of residents that are on an antipsychotics. And they define residents on an antipsychotic as those that don't have a clear indication for antipsychotics, which is or a justifiable indication for these antipsychotics, which they define as schizophrenia, Huntington's, or Tourette's. You've likely heard more recently in the news that this regulation is coming under some increased scrutiny, as there's been some facilities that have had sort of an over-reporting of residents with schizophrenia. So, do these regulations work, and can we, are they effective in reducing polypharmacy? So here's data from CMS showing the prevalence of antipsychotics in long-stay nursing home residents between 2011 and 2021, and, suggesting these regulations may work. Right? The dashed red line shows you where the regulation was introduced. Again, this regulation that all facilities have to report the number of residents that do not have an indication for an antipsychotic that are taking one. And you'll see clearly the proportion of residents goes down over time. But what happens when you sort of regulate a single medication in the nursing home setting, and you may have this unintended consequences? Again, this was a recent publication in JAGS just showing that while we've been successful over the past decade in reducing antipsychotics and opioids in nursing homes, we're seeing a rise in gabapentin, trazodone, and valproic acid. So then a second strategy that's available and encouraged to promote deprescribing in SNFs is sort of quality improvement initiatives. And CMS has long recognized that these quality improvement initiatives are critical to improving care in SNFs. And in 2008, in fact, they created this 5-star rating. This is a summary measure of 5 different domains, includes 10 different quality measures. And among those quality measures are the percentage of residents that are prescribed an antipsychotic, right? Sort of baked in at the end of the day, you get this 5-star rating, and this is publicly reported, and it's available, on NH Compare. And there's been good data to suggest that nursing homes that have higher 5-star ratings are associated with good outcomes, including reductions in 30-day readmissions, right? Another way that CMS has recognized the importance of these quality improvement initiatives in promoting or reducing polypharmacy is through the Quality Assurance and Performance Improvement Program, or QAPI. This was regulated beginning in 2011, and they defined this as a systematic, interdisciplinary, comprehensive data-driven approach to maintaining, improving safety and quality in each facility. And they told each facility that they have to identify, investigate, and use data related to adverse events. And they've got to be able to come up with a plan on how they're going to use the data to prevent future adverse events. Now, participation is not optional, it's required. They'll get deficiencies if they're not doing this, and they have to share their data with state surveyors. Now, while this program is not specific to medications, you can imagine that one of the leading causes of adverse events in SNFs is medications. And so, in fact, medications are a common source for these QAPI programs. All right, here's an example of a QI program that would fit nicely under QAPI with the goal of reducing polypharmacy, and in particular, psychotropic use. Really, the tool they used here was feedback and audit to providers. You can see in the top the providers' performance broken down by unit the number of residents on the unit receiving antipsychotics, antidepressants, different psychotropic drugs, and their performance is compared to their peers. And simply by doing that, you can see in the bottom across these blue bars that show the average number of psychotropic residents per resident, you can see that it worked, that the numbers go down, right? So related then to quality improvement, but yet another tool that we can use to promote deprescribing in SNFs is staff education and communication. So I think it's important when thinking about staff communication, like who is it that we need to communicate with? And probably the first thing that comes to mind is the medical provider. And in fact, of course, every facility has to have a medical director. This is a physician that's in charge of the regulatory adherence and the quality for this facility. However, there's no specific specialty certification. A minority even of our geriatric trainees end up becoming medical directors. There's a lot of retired surgeons and other subspecialists that fill these roles across the country. And certainly there's no requirement that they've had any training in polypharmacy and deprescribing. Starting in 1991, AMDA came up with some specific certification that they recommend for medical directors, but with the exception of the state of California, there's no requirement outside of California for this. And a minority of medical directors actually take this training. To give you an idea, right now there's between 15,000 and 20,000 SNFs in this country, and since the inception of the program in 1991, they've only trained 3,400 providers, right? But even if we were able to train all of these medical directors in polypharmacy and deprescribing, right, we've also got to get down to the prescribers, right? A lot of the medical director's responsibility is the administrative task, and they're not able to see all of the patients. That's the MDs and the NPs in the facility that, again, have no specialty certification or requirements. And while provider reviews are regulated, it's not that often. That is, after the first 100 days, it's regulated every 60 days, alternating again between the mid-level and the physician, right? So I've maybe been a little bit grim about the medical providers' roles in SNF, but what about the rest of the staff, right? I think that it's important that any sort of deprescribing initiatives and communication in particular strategies consider the frontline staff. And who are these staff? These are the RNs, the LPNs, the nursing aides, therapists, administrators, non-direct care staff that really run the ship. I think it's important to note that these are largely a disadvantaged workforce, right? 84% are women, 28% are Black, 15% Latino. These are largely low-income jobs, and in fact, 44% of the SNF workforce lives in low-income housing. Just over a third is uninsured or is on Medicare and Medicaid, right? But these are the people that are seeing the patients day in and day out, and it's really critical that any communication involve these staff, right? So this is a little data that we've collected from a qualitative study talking about the importance of communication with frontline staff when deprescribing in SNFs. And I've got two quotes here. The first from a nursing aide. A resident might be active all the time. Then suddenly you walk in the room and they might be sleeping. And we've got to mention it to the nurse that this person is inactive. And the nurse might be like, well, there's change in the medication, so that's why. And then the second quote coming from a nurse. So if we see that a medication is causing an adverse side effect, we do bring it to the doctor's attention. And then they'll add parameters on it, or they'll say, let's taper or discontinue it and see how it goes. Okay. Oops. So you might ask, is there any evidence that communication training can actually result in deprescribing? And I'll share here this great study by Gentisia, again, looking at the effect of a communication training on antipsychotics in SNFs. This was a quasi-experimental study where they compared rates of antipsychotics before the intervention with after and also in control facilities. And what they saw was a good reduction in antipsychotics during the training and implementation period, harder to maintain over, right? So that brings us to some of the challenges of using these strategies to tackle polypharmacy in SNFs. And first, that's of maintenance of these programs, right? Staff are often very excited about the idea of these programs, but it can be quite challenging given the competing demands on a facility to maintain them over time. And this, of course, is compounded by the high staff turnover, which has only gotten worse after COVID. I think most facilities now are experiencing about 150% turnover per year. And then what's additionally hard is, right, all of these regulations that I've talked with, right, none of them come with any external funding or resources, right? I mean, imagine if you were tasked with a QAPI program for a facility, but they told you you had no budget, you had no extra staff, you just needed to get it done, right? Real challenge there. All right. Finally, I'll comment on sort of one additional existing mechanism to tackle polypharmacy in SNFs, and that's that of penalties. And I'll just put out a real caution. I'll say that nursing homes tend to be highly segregated, with our most disadvantaged patients living in low quality facilities. So pilot studies of value-based care models that have imposed penalties on low-performing SNFs really suggest that we might be perpetuating health inequities by penalizing these low-performing facilities. All right, so then moving then from some of these existing strategies, I think I've convinced you that it's challenging, and that while we'd like to target everybody in a resource-constrained environment, perhaps it's best to target those at highest risk. And who should we be targeting for deprescribing in SNFs? All right. So one option is to target the patient like I presented in the beginning, right? Somebody that's on 22 medications, somebody that exceeds some threshold, and certainly that's a reasonable option. But I'm going to present to you some data that I hope will convince you that another sort of maybe feasible and attractive option is targeting patients who are at high risk for falls, or in particular, injurious falls, right? And why might this be a good idea? Well, first of all, these falls are common. 1 out of every 2 SNF residents will fall each year, right? Falls are the leading cause of hospitalization and ED visits for SNF residents, okay? But importantly, medications are probably the most common modifiable risk factor for falls and injury in this setting, right? Strong evidence links a number of different classes of medications with falls, and I've shown here, and it goes beyond just the psychotropic medications that we typically think of. This meta-analysis is getting a little outdated, and I've gone ahead and added some classes of drugs like gabapentin, where I feel like the evidence is getting quite strong, but are not typically represented in these older meta-analyses, right? So another reason why it might be appealing to target SNF residents who are at risk for injurious falls is that really injurious falls are a high priority for SNFs, right? For the past decade, SNFs are required to report the proportion of residents or the rate of injurious falls in their facilities. And this is a publicly available quality metric. In fact, this is one of the factors that goes into that 5-star rating. And you'll notice this is shown in this figure here that despite this, there is tremendous variation in rates of injurious falls across facilities. And in addition to sort of the quality side, these injurious falls are a real nuisance for SNFs because they're one of the leading causes or sources of litigations for SNFs. Right. So then you might say, well, do we have any evidence that deprescribing reduces falls in SNFs? And this group is likely familiar. Certainly in community dwellers, the evidence is more limited that deprescribing reduces the rate of falls, but I hope to convince you that it's an effective strategy in SNFs. This meta-analysis is specifically looking at deprescribing programs that were implemented in SNFs, and it's broken down here. You can see by the type of program, whether it was focused on medication review or educational training, direct discontinuation, etc. And overall, you'll see a very sort of a mild or modest reduction, but a statistically significant reduction in falls across these different program types. The two types of programs that seem to be the most effective are those at the top, this medication review, and then adverse drug reaction profiling, right? I'm going to spend the rest of my time talking about the medication review. All right. So if we think about what a medication review would look like in somebody at risk for injurious falls, right? It's got to tackle deprescribing of the meds associated with falls, like our psychotropics, right? But you also might want to deprescribe drugs like proton pump inhibitors that have been shown not to increase falls, but have been shown to increase fracture in the setting of a fall, right? And then it's hard to think about preventing injury in nursing home residents and optimizing medications without also considering osteoporosis treatment. And you may be asking, well, is there any evidence that osteoporosis treatment is effective in reducing fractures or injuries in this setting? And I think there is. There's limited data, I think, from observational studies and randomized controlled trials, again, where the outcome is a surrogate marker of EMD. Here's a data that where we've looked at this in a large observational data, nursing home residents with Medicare claims linked with the minimum data set. And we've used propensity scores to compare new users of bisphosphonates, or sort of a potent, effective osteoporosis medication, with new users of calcitonin. And you can see that even in this nursing home residents, these curves diverge somewhere between 1 and 2 years, again, suggesting that the bisphosphonates are an effective, sort of a modest but effective treatment prevent hip fractures. All right. So then sort of given that background and sort of what I'm thinking about when I'm thinking about a medication review for nursing home residents at risk for injury, I want to tell you about a pilot program that we conducted. Really delighted that Laurie Herndon's on the call as she was very involved in this work. This is the Nursing Home Prevention of Injury and Dementia, or we called it the NH Pride study. And the purpose of this was to pilot test a remote injury prevention service that would prevent injurious falls in 5 nursing home facilities. So this injury prevention service, what do we mean by that? If we drill down, it's really a medication review. And the medication review considered deprescribing fall risk increasing drugs, as well as consideration of osteoporosis treatment, right? So again, this shows the design and the study population. Again, this was a non-randomized trial. These were long-stay residents at 5 different facilities at risk for fracture. And we identified eligible residents, sort of out of the 274 total residents. We identified those that were high risk in two different ways. One, we used a validated screening tool from items from the minimum data set to identify people at high risk. And then we said, hey, if there's anybody we're missing and staff want to refer them, by all means, we took staff referral too, right? We ended up having to exclude some residents that transferred to another facility or died before we were able to complete their chart review. But in total, we ended up with 46 residents that were really sort of eligible to participate in this program. We were able to successfully argue that this is quality improvement, right? This is standard of care and what we should be doing for all nursing home residents. And so we got a waiver of informed consent. Instead, we gave patients and proxies the information about this study with the ability to opt out. Yeah. So then in the next slides, I'll show you a little bit more about what the intervention looks like, right? So really key and central to the intervention was this remote nurse care manager, right? And she had access to all of the electronic medical records, was able to review their medications and the indications for these medications, right? And she participated in these weekly, very short phone calls, these virtual interactions with the direct care staff. Again, the nurses and the nurses' aides that know the patients well, right? Hey, we were thinking about, or we noticed this patient was on trazodone and was getting this as needed for agitation. Can you tell me more about that? Do you think they really need that? We were thinking about deprescribing that, right? So after getting the buy-in from the direct care staff, the care manager kind of came up with a plan to deprescribe medications associated with falls and injury, and also to consider osteoporosis treatment for eligible patients, right? So at that point, our plan was that the nurse manager would conduct some shared decision-making with the patients, or more typically the proxies in long-term care. Again, these are the recommendations that our team is thinking about. And then they would take this afterwards to the primary care doctors. Turns out our primary care doctors weren't too thrilled about that model, and they really wanted us to vet the recommendations with them first before we spoke with the patients or proxies. And so that's what we ended up doing. One additional layer in this NH Pride intervention was educational. So we offered, again, the direct care staff monthly case conferences with our interprofessional team. We encouraged them to bring in sort of a challenging case of a patient either with polypharmacy and or falls and injury. And together we sort of strategized on how we might tackle the problem. So this slide shows some of the communication tools that we used in this program, right? Sort of after the plan was a little bit, after a preliminary plan was drafted, what was presented to the primary care doctors and our practitioners in the facilities, right? You can see here on the left, the first page, just kind of really big and bold, your patient's 2-year risk of having a hip fracture, 10.6%, kind of, to grab them, tell them a little bit more about our study. And then on the right, the back page is really the meat of the recommendations. So, mirtazapine, we're recommending reducing the dose by this. This is what you need to monitor for. And does the provider accept the modifications or decline this? And we did the same thing for osteoporosis treatment. You can see down in the bottom. All right. So again, this was a feasibility study, a pilot study, and our primary outcome was really the proportion of recommended drugs that were deprescribed and the proportion of recommended prescriptions for an osteoporosis treatment that came to fruition, okay? But our secondary outcomes included demand, that is the number of residents that were enrolled, acceptability, how did the staff feel about these huddles and case conferences, Persistence, we were able to look just 4 months into the future and whether they stuck. And again, some exploratory analyses looking at the rates of adverse events, falls, and fractures in this population. Okay. All right, so here are the results. So in total, you remember we had 46 residents who were eligible, one that became really had an abrupt change in their condition, and we felt like our plan was no longer appropriate for their goals of care, and so that we did not pursue the plan further. So again, the plan went forward with 45 out of the 46 residents. And you can see out of the 45 residents, we made 93 deprescribing recommendations among 36 residents. For 22 of the residents, the provider actually agreed. And all of the times, the resident or the proxy agreed once the provider was on board. And then 21 out of 22 residents, we were able to get the order written for. You can see these largely stuck. There were 2 residents that died during follow-up, but persistence, again, you can see pretty good at 4 months. If you look on the osteoporosis side, I would say uptake is less, right? Out of the 45 residents, we just recommended pharmacologic treatment in 20 of them, right? We were conservative and wanted to make sure we were recommending it in persons with a reasonable life expectancy that would stand to benefit. And the provider agreed just half of the time. Again, the resident proxy a little bit less, and only 6 out of the 20 orders were actually written for. 5 stuck at 4 months. So, I'll point out too that we were all set and ready to implement this March of 2020, with our first facility being one in Massachusetts, and obviously had to pause due to COVID. We were very fortunate, and this was a remote intervention, but obviously needed to give the facilities some time to tackle this COVID pandemic before they were ready to work with us. And it was interesting, when I submitted this for publication, people were, that this is a null study, that this didn't work. And my take, and maybe I'm an optimist, was actually this is not bad, right? That out of 36 different residents where we made a recommendation, that 21 of them, we were actually able to get the order written for, particularly when we're talking about end of 2020, 2021, a very difficult time for these facilities. And I think it really speaks, again, the point that injurious falls are a priority for these facilities, may be a really good motivator for deprescribing intervention. Right. And I'll move then to the adverse events, and they were pretty rare. We had 1 participant over the 4-month follow-up that had an antidepressant taper, that had some irritability that could have been related to the taper, I have to say. We had 2 residents with a recommendation for osteoporosis treatment with adverse side effects. One was a resident where we suggested calcium supplementation and they experienced constipation. The other, it was a prescription, again, treatment, the bisphosphonate, that was discontinued due to concerns of dysphagia. Right? In adverse events, 3 deaths, 6 hospitalizations, none were felt related to any of the medication changes that were made or recommended. Notably, we did have 2 residents in this program with fractures. Both were residents that were recommended for osteoporosis treatment and were not started on treatment. And again, I'm not necessarily saying they would have prevented it, but it does show you that identifying these patients that are at high risk, it's a good place, it's a good patient population to target. So staff feedback, I think overall staff were pretty satisfied. 17 out of 21 staff reported that they were very or somewhat satisfied with the program. 15 out of 22 said that it had no impact or actually reduced the time that they were spending on these issues, right? We also identified a number of areas of program refinement. And first, I think we did a really good job of engaging the front line and getting them excited about this program. We didn't sufficiently consider provider buy-in, right? We heard a lot of times that the providers were really just there to put out fires. They didn't have enough time to think about preventive medicine and sort of their problems that weren't acute. And that if we wanted them to do that, that we needed to align these recommendations with the provider workflows. And the challenge of this being that a given provider is only seeing a patient maybe every 120 days, right? Or else with these scheduled care plan meetings. Another area for refinement that we heard was the challenges of sort of conflicting recommendations coming from these consultant psychiatrists. So most SNF facilities consult with a psychiatrist. Typically, this is not a geriatric psychiatrist. This is, an external psychiatrist. Typically, they don't even come into the facility. But when the facility consults for difficult behavioral issues, right, they make medication recommendations. And so providers felt very uncomfortable that they were being put in the middle. This consultant psychiatrist says, give them gabapentin. Your consultant team says, don't give them gabapentin. Who do I listen to? And I think it's clear going forward, we're going to have to engage those consultant psychiatrists. And finally, I think, again, we saw lower uptake with the osteoporosis treatment than we did with the deprescribing recommendations, and education surrounding osteoporosis treatment is going to be important for staff and patients. So then I'll close then just by saying we're looking forward to continuing this work. And I've got a few of my team members, Kylie McLean and Lori Herndon again on the team today, through a funding announcement to reduce secondary osteoporotic fractures from PCORI. And we're calling this preventing injury in SNFs through medications. While we've been delighted to be selected for funding, we don't actually have funding yet. We're anticipating this will start in January, right? But sort of our overall objectives of PRISM are to conduct a randomized control trial in patients receiving post-acute care in SNF after a fracture. Here we've pivoted from the long-term care setting to post-acute care. And here we're going to compare the effectiveness of 3 different models: a deprescribing care model, a bone health model, or a combined model, right? With the primary outcome of injuries fall. And then PCORI, again, not being fond of usual care arms. I think ideally we'd like to know how these different models stack up with usual care. And so in AIM 2, we're planning to compare the effectiveness of these kind of 3 different models on injurious falls and fractures in patients treated in the randomized controlled trial compared with 100 matched concurrent control SNF, right? So this figure just illustrates our study design. This is a cluster crossover design. So that is, each facility is going to get all 3 types of interventions, right? But they're going to get them in a random order. So the facility 1 may get the deprescribing first, the combined intervention second, the osteoporosis treatment, the bone health third, right? But any patient admitted to that SNF during that intervention period is going to get that intervention, and that's regardless of whether they stay in the SNF or are discharged into the community. Whatever they were admitted with, that's the intervention they're going to stay with. We're hoping to follow people for a mean follow-up of 2 years after admission, right? So we're aiming to enroll 42 facilities, and this wouldn't be possible without partnership with the American Healthcare Association. And in particular, we'll leverage the long-term care data collaboratory, right? Really the only criteria for enrollment for a SNF is that they have to be willing to participate in the long-term care data collaboratory, and they need to have at least 400 admissions annually, right? So that we get an adequate sample size from each facility. Although it's not an absolute requirement, we're hoping to prioritize facilities with at least 15% patients from racial and ethnic minorities. Right? And then at the patient level, this is a pretty pragmatic trial. The inclusion criteria is you're at least 65 years old and you were admitted to a participating SNF with a fracture, right? We'll exclude you if the fracture was only at a non-osteoporotic site. That is, if you only had a face, digital, or skull fracture, or if the fracture was felt to be due to a tumor or infection, or if they were receiving hospice. But our hope, our goal is to enroll about 3,780 patients in this trial. Again, pragmatic. We're not getting, we're saying we're asking for a waiver of informed consent for this activity. Right, this slide shows our primary and secondary outcomes. You can see the primary outcome is injurious falls and fractures ascertained by Medicare claims. Secondary outcomes are going to be osteoporosis treatment, both at the time of discharge and at 90 days. We can get that both from the EHR and from Medicare claims. We're going to look at some sort of modified drug burden index, and boy, I'd love feedback on that, as I'm worried about what an appropriate measure is in this population. We'll also, again, given that it's PCORI, have a number of patient-reported outcomes at 90 days, including a measure of medication burden, falls self-efficacy, pain, depression, sleep, right? So in addition, we're going to try to measure shared decision-making in a subset of patients. And we've proposed that we'll do this using the option survey, or sort of a modified version of this option survey. It's a 12-item survey, actually, that was designed to measure the quality of shared decision-making. Our plan is, again, that at least on our subset of patients, that a third person will listen in to these phone conversations that the remote nurse manager is having with the patient's proxies, and again, sort of rate the quality of shared decision making. All right. So I'll close there just by saying that there's lots of opportunities to deprescribe in SNFs. I think it's a really, for those who are interested, young investigators, this is just a hot area. Polypharmacy is a real problem, and there are some movable targets, right? We do have some existing strategies, including regulations, quality improvement initiatives that are part of SNF's culture already, that can be leveraged, again, to promote deprescribing. And I think it's key to leverage the existing interprofessional team structure that already exists in these SNFs with education and communication interventions. That being said, I've clearly pointed out some challenges too, including the limited resource and the limited physician involvement in these facilities, as well as the high staff turnover. Nonetheless, I think that patients who are at risk for falls and fracture, right, that this is a real priority for SNFs. They're interested, even despite their competing priorities. And that targeting medication review in these patients is really a logical way to move forward deprescribing efforts. And these medication reviews might include not only the deprescribing drugs related to falls and injury, but also consideration of osteoporosis treatment in persons with adequate life expectancy. So lots of people to thank. And again, my team at EHSL and Duke and Brown and AHCA and others. Are welcome. I want to leave time for questions.
Great, thank you, Dr. Berry. What a fantastic presentation, and look forward to the upcoming study. Please put your, now it's time for question and answer. So please, attendees, please put your questions into the Q&A bubble icon on the bottom toolbar. And our panelists can also put in questions too. While we're waiting for questions, you had mentioned that your intervention, the planned one, given that it's post-acute patients in the PRISM study, is going to extend after nursing home discharge. I was just wondering a little bit about the, how are you designing this intervention, or more than one intervention in the nursing home and through discharge?
Yeah, great question. So we're hoping to get most of the medication changes done in the SNF stay. So on average, patients have about a 2-week, SNF stay, and sort of convincing providers. We've spent some time this past summer sort of interviewing providers, thinking about what it's going to take to get them motivated, but recognizing, you can't just expect that the primary care doc is going to do this. The primary care doc may never see these patients, may not know that they were in a SNF, may not know really an accurate medication list. So yes, our goal here, a little different than what we did before. We're actually kind of gonna, the norm when you enroll in this study is going to be, our team is going to reach out to the patients first. We're not going to wait for the providers. Providers, I guess, have the right to opt out and sort of stop that plan. But I think if we wait and sort of for the permission of the SNF providers, we're not going to be able to get this done.
Yeah. And of course, you've probably seen Shed Meds, which has done some work to try to take care of medicines through these transitions, and that's recently published. We have a question from Matthew Groudon about ways you've thought about achieving better provider buy-in in your initiative, and then secondly, better aligning with consultants, especially psychiatrists, on these, prescribing recommendations.
Thank you. So we have spent a lot of time thinking about messaging, and we presented providers. We interviewed post-acute providers this summer, 30 different providers, and gave them sort of examples of messaging of what would make you sort of more likely to deprescribe or less likely to deprescribe. And sort of, I think what they don't want to be, they don't want to be shamed and told that the primary care is too busy, so you have to deal with it. But they want to, kind of, we can all work together to help assure safety. That having a fracture is kind of like having a heart attack of the bones. It requires sort of a urgent changes, else you're going to have another one. Those sort of messaging seem to resonate. And I forgot, you said the consultant pharmacist. So that one's challenging. Any suggestions?
Actually, the question was about specialty consultants, I think.
The special,
meaning psychiatrists, other specialists. But I suppose you could talk about the pharmacy consultants as well.
Oh, sorry. And that's when I said consultant pharmacist, but in my head I was thinking the psychiatrist. I misspoke. Yeah, the psychiatrist the problem, of course, is they're not in the facility, and they're like, well, why are you calling us if you don't want us to prescribe, right? So the intervention really needs to be upstream to the direct care staff, not to call for something that you don't want, right? And that's challenging. Again, I'm hoping that in post-acute care, yeah, that maybe this is less of an issue, but it's tricky.
Great. While we're waiting for other questions, another you acknowledge that providers are physician providers, but also nurse practitioners, other providers. I was just wondering how your past experience with nurse practitioners might differ or may not with physician prescribers.
Right. So it's very clear to us that we've got to get nurse practitioners on board because they're more involved than the providers in the prescribing and SNFs. And I think I think there were like of the 5 pilot facilities, there were facilities where we did that well, and there were facilities where we did not do that well. So I think I think the take home, what I'm hoping is different from PRISM, from NH Pride, is that we've kind of already been practicing and trying out our messaging and sort of thinking about ways to engage them. I feel like in NH Pride, we were a little behind the 8 ball. We spent so much time thinking about how to engage the frontline staff. It was sort of like an afterthought to engage the providers, if that makes sense. And I don't know that I don't know that in our experience it was different, the nurse practitioners and the physicians. Getting either of them is engaged is tough.
Thank you. Great. Just as again, if you have questions, please type them for us in the Q&A. I just want to give a chance maybe to the panelists in case they were holding back to ask any questions. I do have others, so I can keep going.
No, whatever is a good use of anybody's
Yeah, I mean,
time. No pressure.
This one is actually more of a just an agreement, because you had said in your Pride's, NH Pride study, that some people pointed to it and said, oh, this doesn't look successful because, only a third of recommendations were implemented. But when I see the data from other interventions, deprescribing interventions, it's about a third, or a quarter to a third of recommendations, deprescribing recommendations, are implemented. So I think that, and unless you've seen otherwise, that's kind of the ballpark that I've seen.
I agree, and I think one of the I guess I hinted at it with the first case that I had. I think sometimes the patient's goals are not going to be concordant with deprescribing. You might want to, but it's really not concordant. And I think we certainly found that with NH Pride. I see that in my own clinical practice. And yeah, I agree with you. I was like, I think a third is pretty good, is still meaningful. Yeah.
Okay, well, just a big thank you again to Dr. Berry and also the support team, Jen and Vanessa and Jonathan and Raha. So also wanted to remind folks that the recording for the webinar will be posted on the US Deprescribing Research Network website. There is also an evaluation survey that will be emailed to attendees, so please look for that and fill that out. We do have a webinar scheduled in January. We may have one in between, so we will let you know if there's, but that we for sure we have another USDN webinar in January. There may be one earlier as well. And Jen, do you have anything else that you wanted to add?
No, I thought this was really wonderful. Thank you, Dr. Berry, and good job with that PCORI funding. I encourage all the junior investigators on to like take note. It's just cool, like just to watch the beauty of how you've built this research agenda and stacked it up this way. So kudos to you. Thank you so much.
Thank you. And to any junior investigators that have any interest in nursing homes, do reach out. I love this topic. Thank you.
Thanks so much.
Bye.
Take good care, everyone. Bye-bye.